Hi, everyone. Thank you all for joining us. It's good to see the turnout. I know it's not the best of circumstances to need this kind of a turnout, but as always, very proud to be a part of the AAP California Chapter 2 community. So I wanted to just give a quick overview of how we're planning on spending the time we have today. Lisa and I are going to talk a little bit about sort of background conditions that have led us to the situation that we are seeing right now at the border, and then, as some of you know, in our area in Long Beach and Pomona with the emergency intake sites for unaccompanied children. And then we're going to leave plenty of time at the end for discussion. A lot of you have been working with immigrant children in a lot of capacities, both in the setting of this current surge as well as just throughout the rest of your careers. And we really wanted to leave a time for people to talk about the issues that they're facing and to start planning and thinking ahead about what might be coming and how we as a community can prepare. Next slide. Okay, Dr. Gantz and I have no conflicts of interest to disclose. These are the learning objectives for today. We're going to describe the current crisis involving unaccompanied immigrant children, and as well as with emergency intake sites. And then we're going to talk about how to incorporate trauma-informed care principles and best practices into providing medical care for unaccompanied children. We'll also talk about local, regional, and national resources for immigrant youth and families. So before we get started, I just wanted to do a quick word on definitions. From the standpoint of the U.S. government, there's the first big split in terms of how they label and think about children at the border is whether they are unaccompanied or accompanied. An accompanied child refers to a child who has arrived with a parent or a legal guardian. They're often referred to by DHS, which is the Department of Homeland Security, as a family unit. The other term they use is one that's called unaccompanied alien child. As you can imagine, that's not a very child-friendly term. Many of us, I think, probably have been traumatized by hearing it in our own youth, maybe as immigrant children or children in immigrant families ourselves. And so there are preferred terms that are non-dehumanizing and non-othering that we'll be using throughout the course of this talk. Primarily unaccompanied child or unaccompanied children, UCs will be the abbreviation we use. Unaccompanied children who are defined by law as a child who has no lawful immigration status in the United States, has not yet attained 18 years of age, and with respect to whom there's no parent or legal guardian in the U.S. or no parent or legal guardian that's available to provide care and physical custody. Next slide. So the reason we're talking about this now, as many of you know, is that there are many children, well, there's a lot of arrivals at the southwest border, both adults and children, and in particular, the number of arrivals that are unaccompanied children is very high and represents the majority of people that are arriving at the border right now. The lines on this graph you can see represent different fiscal years. As a reminder, the fiscal year goes from October to September. And you can see that the blue line is our current fiscal year 2021. You can see how it's continuing to rise up much higher even than 2019, which was pre-pandemic in terms of arrivals. The chart on the figure on the right, you can see shows numbers of unaccompanied children that are arriving. And again, we're only part of the way through this fiscal year, and you can see how sharply the numbers are rising, and what we anticipate would be much higher numbers in this fiscal year. Next slide. So over 400,000 unaccompanied children across the U.S. border since 2003. The data for fiscal year 2020 is that 84% of unaccompanied minors or children are 13 years or older, and 68% are male. You can see the countries of origin for most of the children. They're from an area called the Northern Triangle. In March of 2021 alone, 18,890 unaccompanied children arrived at our southwest border. So you can sort of see the numbers. Next slide. And why is this an urgent issue here? So if you look at the top 5 destination countries in the U.S. for unaccompanied children as of March 2021, you'll see that California, and specifically Los Angeles County, is number 2 on the list. And it really depends on, at what point in time you take a snapshot, whether or not we're number 1 or 2. We generally are in the first 2. So this is a really relevant issue for us. even outside of the presence of the current emergency intake sites. Slide. And there are many reasons for that. I'm not going to spend a lot of time on this, just given the information that we'd like to share today. But the reasons why children flee their countries of origin and come to the United States are complex. There's many push factors as well as many pull factors, and you can sort of see on here poverty, fear, disasters, unemployment, as well as concerns about safety, gang-based or gender-based violence, and the opportunity, in terms of push, and then in terms of pull, the opportunity for safety, opportunity, stability, or freedom. Next slide. The journey is often complicated and has a lot of concerns, obviously, for children's safety once they arrive in the United States as well. And again, we're not going to talk about the first part of that, the journey, in detail right now, that we can talk about it in the Q&A, but I did want to quickly review what the process is for children once they arrive at the Southwest border. So the first is children are typically immediately, once they're arrive and come across the border, they're detained in Customs and Border Patrol in a processing center. And there's two big forks in the road for children once they arrive. So the first is whether they're accompanied or unaccompanied. And then the second is what country they come from in terms of country of origin. And there's a different set of rules for both contiguous versus non-contiguous countries, contiguous being Mexico and Canada. I'm not going to talk too much about the part that's already being highlighted right now, which is about children that are arriving in an accompanied unit. But when you look at the flow, which is going to come up in a second on the slides, for unaccompanied children, you can see that unaccompanied children are treated differently, and there's a set of policies that's in place to help protect immigrant children, and part of this, unaccompanied immigrant children, and part of this is because they're considered high risk for trafficking and being otherwise victims of violence. So unaccompanied children are placed in shelters or other facilities that are operated by the Office of Refugee Resettlement, which is under the Department of Health and Human Services with the U.S. government. And then children, unaccompanied children, actually applies to accompanied children as well, but are not supposed to be held in any kind of custody for any prolonged period of time. And so children coming out of these ORR shelters, as we'll describe them, they attempt to release them into the care of community sponsors for as quickly as they can. And then the children are supposed to stay in these community settings with their sponsors for the duration of their immigration proceedings. Slide. So the CBP processing centers are the ones that you've likely seen photos of in the news. They're otherwise known as La Hielera. The freezer is the other name for it. These are not good experiences for children. You can see from the pictures, children are often given just a mylar blanket. They're either on cots or like just those kind of pads you can see there, or sometimes just flat on the ground with very little between them and a cement floor. The lights are on. It's very, very cold, hence the name. It's not a child-friendly site. And so there's obviously been a lot of press about this and a lot of concerns from child advocates about whether or not anyone, let alone children, should be kept in these processing centers for a long time. Next slide. So as we discussed, children are supposed to be released from CBP custody efficiently and quickly, and this is through a protection that's called the Flora settlement that we're not going to go into in detail right now, but again, can talk through a little more in the Q&A. And these children, unaccompanied children, are supposed to go to ORR shelters. ORR shelters are supposed to be sort of child-friendly, right? They provide appropriate health services, they provide vaccines, there's opportunities for education, mental health support, there's shared bathrooms and showers, but they also get sort of hot meals, recreational activities, and they also get some limited legal services. So this is where children are supposed to end up if they're unaccompanied arriving in the United States. There is a limitation in ORR shelter beds. Because the number of children arriving fluctuates based on the year that we're looking at, as we saw from that graph earlier. ORR has a set number of permanent beds, and then they have a set number of temporary beds that they use when there's a surge or a rise in the number of children that are arriving. At this point in the crisis where we are now, and this has happened in the past as well, we have gone way past all of those beds that they have set aside. And so the question is, do we let children languish in CBP custody in those freezer rooms, right? Or do we allow them to have an alternative site where they can be taken and have maybe not all of the protections of ORR custody, but have at least the key protections of ORR custody. And those are what's called the emergency intake sites. And we're going to leave time in the discussion to talk about that. I'm framing it one way now, but I just want to say that there's two sides to that discussion, right, in terms of, you know, it's the conditions relative to CBP custody versus the conditions relative to ORR, and then the bigger conversation of trying to get children into the community where we know that they are the safest. Next slide. So what happens to kids after they're released from ORR shelters? So 76% of children are reunified with close family, 53% of them with parents. 9% of children are released to distant relatives or to unrelated adults. And then 15% actually age out into adult care. And many children, not many, but a small set of children do actually return voluntarily to their home country. And there can be a range of reasons for why that would happen, or they receive another designation. Next slide. And so I just want to talk a little bit about the current situation. So for fiscal year 2020, as you likely saw in the setting of the pandemic, the border essentially was closed. And no one was coming across the border. Because of that, the numbers were very, very low. In this, since the Biden administration came in, they have taken a policy that was in place called Title 42, which had closed the border because of the pandemic. And they have rescinded only part of it, not all of it, but they have rescinded part of it just to allow for unaccompanied children to be able to come through. And that really is a lot of what we're seeing in terms of the numbers that we're seeing right now. There are a few other things that have been going on that I'm not going to talk about in terms of the migrant protection protocols or issues with sponsors. But the creation of the emergency intake sites has been the response by the Biden administration to try to create sort of their effort at child-friendly services. And again, we can talk a lot about the limitations of what is offered in those settings. And so at this point, where things are at is that at the peak of the number of children that were in CBP custody, there were 5,700 children in CBP custody at the end of March. As of May 1st, there is now only 677 children in CBP custody, and that's an 88% decrease in the number of children in CBP custody. They've created 14 of these emergency intake sites, which we'll talk a little bit more about a little later on. But again, like I said, there are two of which in our area, which is at the Pomona intake, the emergency intake shelter, and then the one in Long Beach at the Long Beach Convention Center. And there's a total of 22,000 children that are in HHS care at this time across the country. So these numbers are big, and their impact on children and their well-being, both now while they're in these shelters, as well as once they're released and begin arriving in our communities is important. As of March, the average length of stay that a child was in these emergency intake shelters was 35 days, and we don't know if it's going to be longer. They keep saying it's going to be shorter, but we will all see. But these are issues that we're all going to be facing and trying to prepare for as we go forward from here, these children all arriving. And they may not be the children that are at these emergency intake sites, but we know nationally it'll be the children arriving from across the country. I'm going to hand off. Oh, sorry. So on this slide, so I'll just show you the emergency intake sites that are in California. So you can see the Pomona Fairplex, the Long Beach Convention Center, and then the San Diego Convention Center. And we've put the dates on here when these sites all opened. The pace in which these sites are opening is huge, and the majority of the sites across the country are in partnership with academic medical centers. And so many of you that are affiliated with academic medical centers may have colleagues that are either working at one of these sites, or even across the country, you may know people that have gotten involved with working at one of these sites. Lisa, do you want me to say a few words about the sites themselves? Okay, sure, you do. Great. So this is the total number of children that that we talked about already in terms of numbers of 677 that are in CBP custody right now in the 14 sites. One of the big focus areas of these sites is reunifying children with sponsors in the community. So they have caseworkers that are assigned that are attempting to reunify children with family members. So they're identifying the family members and then also doing a level of screening depending on the child's underlying risk factors for trafficking or trauma, or based on their age of being vulnerable. And then this is just the same slide. You can see the emergency intake shelters. They're largely in convention centers or places where there's sort of big, long hallways. They set up cots where the children will sleep. The children are in dorms. There are COVID positive and COVID negative children that arrive at these sites. And so each site is tasked with figuring out how they're going to cohort those kids. All of the sites are supposed to offer education. They all offer an initial medical health assessment. It's a limited health assessment in terms of what they cover, but they do have a health assessment that is supposed to be done within 48 hours. And then they do have to have capacity to handle any urgent medical needs that may come up. They're supposed to offer case management as well as mental health services. And then they offer 3 meals at least throughout the day, though again, each site is allowed to set up how they want to do that themselves. And then, like I said, school and recreation areas. But, you know, the pediatricians that are involved in these sites and other health professionals, there's a lot of say in terms of how you specifically set up the services that are there. And again, in the discussion, I hope we can talk a little bit just about our own experiences and, you know, what that has been like as we think about how we prepare kids to not re-traumatize them in these sites, but also then prepare them for success once they are released into the community. All right, I'm going to hand off at this point to Dr. Gantz.
Great, thank you so much, Dr. Shah. If I could just ask anyone who hasn't muted themselves already to please do so. And we're going to be switching gears now and really talking about what's going to happen after these children leave these sites. As Dr. Shah discussed already, we know that LA County is the #2 destination county. So not all of the children in our local sites will end up locally, but we can expect that a significant portion will, as well as children that are housed at other sites in Texas and other states will eventually end up in LA County. So what will these children need upon their release in the community, and how as we can, as pediatricians, support them in that transition? And basically the next portion of the talk before we open to discussion will be focused on reviewing best practices, how to approach this population, and hopefully equipping you with some resources to use in your own practice. Rest assured, there will be some QR codes if you'd like to scan with your phone or take screenshots, but please know we will also be sending out a collection of the resources. So you do not need to take notes. We'll be sending this all out and you can access it after the talk. But really the cornerstone here is most of these children have experienced trauma either in their home country along the journey or in the process of passing through the sort of pathway that was just laid out for you. So trauma-informed care is really central to approaching working with this population in terms of the medical care we provide, as well as getting them connected with mental health care. And then they have some unique needs beyond the usual social needs that families have. They have some unique legal challenges that they will face. And I just want to highlight a few resources that the AAP nationally has already put together that if you're not familiar with already can be great to refresh. So AAP has a trauma toolbox that specifically provides guidelines on how to practice trauma-informed care in your clinics. One of the first things to remember is really recognizing trauma and always having trauma on your differential. So thinking that you know, children who might be presenting might not come in and say that they're depressed or anxious or that they have PTSD. They're much more likely to come in with toileting issues, issues with feeds, issues in school, behavioral outbursts, and really thinking about that in your differential when you're approaching a child with a problem visit. Another resource to keep in your back pocket is a new toolkit that was just released in February of 2021. This came from a group in Texas that did key informant interviews with unaccompanied children, caregivers, as well as providers that care for them in Houston area. And I'll be going over some highlights from this toolkit. If you can please mute yourself. Okay. So really, I think continuing on this theme of trauma-informed care, they give some recommendations about what that means for this population and how that impacts the way you conduct your interview. And number one, first and foremost, is making sure that you're using the family's preferred language. And we should be making no assumptions about what that language is. Although many of these children are coming from the Northern Triangle, Spanish might not be their preferred language. There are large parts of Guatemala and some of the other countries in the area where there are many indigenous languages. So really establishing what is the preferred language for the child and their caregiver prior to moving forward with your visit is crucial. And depending on their level of comfort and their level of literacy, although most of us start with open-ended questions, you might need to narrow down to closed-ended questions if the family is having a hard time understanding what you're really asking. 3 and 4 are really about transparency and using normalizing statements. So really helping families understand why you might be asking a certain question, normalizing statements like we ask all of our families about this, and also giving them permission and agency to refuse to talk about something if they might not be ready to do so, or giving them options such as taking breaks. As far as building trust, really using the family's culture as a guide and approaching these individually, although we've made some generalizations about common experiences, each child that has undergone this experience had a unique experience. And they're really feeling a lot of uncertainty at this time. And although they themselves as an unaccompanied child are not at risk for deportation per se, they are already in a legal process that is going to affect their immigration status. They may have family members that are at risk for deportation, or they may feel that they themselves are at risk. And they are facing challenges in almost every part of their life, from their social life, their family life, school. And unfortunately, a lot of them are also experiencing racism and xenophobia as they adjust to their new culture and their new home. Some key themes from the focus groups in this toolkit talk about remembering that a lot of these children are teenagers. So they're going to go through all of the usual teenage issues with social and romantic relationships, kind of learning to build on their independence. Unfortunately, compounded with that, they are also facing often discrimination or racism at school or in their communities. Number 3 talks about just kind of the breadth of the needs that they have. As we've mentioned, there's many different resources that they need to be connected with, but really central to all of these is safety, physical safety, emotional safety, and really replacing some stability and safety in their lives after a period of a lot of instability. Number 4 really highlights the importance of legal support. These children are in a process that is going to determine whether they're allowed to stay in the United States or not. And there's a lot of data that shows that children who are represented by lawyers have a significantly higher chance of being able to stay. So one of the things that might be identified on your visit, and one of the most important things you can do besides connect them to mental health services and address their medical needs, is also connect them with a lawyer. Number 5 really talks about can often be some complex caregiver dynamics. Keep in mind that a lot of these children might be reuniting with a family member that they have not seen in a very long time, or even a family member that they've never met before. For parents who may have made the difficult choice to leave their child behind in their home country and they're now being reunited as the child is arriving, there can be guilt or resentment, a lot of very complicated emotions, and sometimes that reunion can be a particularly challenging transition for both the parent and the caregiver. Number 6 is really getting at the financial worries that a lot of these families might be facing. There's a lot of fees from legal fees, as well as, the supplies that will be needed for this child as they usually arrive basically with the clothes on their back. So there's a lot of financial strain that's put on a family as they transition to this as well. And I think, in summary, trauma-informed care is really about creating safe spaces in your clinic, really making sure that these children and their families know that they're welcome in your clinic, that this is a safe place for them to come, this is a safe place for them to talk about things, and that they do not need to worry in your clinic about ICE or CBP coming in. And that's something that, if you have not already, is worth exploring with your practice or your workplace to make sure that there are policies in place of what would happen if an immigration raid were to happen, and what staff can do to support and create that safe environment for patients. I'm going to be transitioning now a little bit to medical care. A lot of this I'll be going fairly quickly through because it's really reference material and it's best used if you pull up the actual toolkit itself. The AAP has a really beautiful toolkit that's been available for a few years now that has a very detailed clinical guidelines section, but also has a lot of good background information about caring for this population, access to public benefits, mental health, as well as advocacy opportunities. So if you look at the list, this is taken from the toolkit, really approaching a first visit with an unaccompanied child is essentially your regular well child check with a few extra considerations. You are going to be asking all of the usual past medical history, but then there might be some relevant information from their immigration history itself, or some cultural practices or experiences that they may have had in their home country. And for the most part, we expect that a lot of these children who are leaving from the EIS shelters will likely have a packet in hand, and they have a letter that we'll be talking about in a few minutes that they'll be instructed, the caregiver will be told, bring this to your doctor. So they might come in already very clearly identifying themselves that they are an unaccompanied minor and that they have been through one of these facilities. However, if they don't, and as you're talking with them, you get the feeling, I might be interacting with a child who has been through this. How do I know for sure? And really the answer is knowing for sure is not always necessary. And it's usually not appropriate to directly ask about someone's immigration status, but asking enough to understand what their social needs, their legal needs, and their mental health needs is really the crucial thing that you want to think about. You're going to be conducting a social history as you normally would, but just pay attention for clues and ask open-ended questions and follow-up questions, but always pausing to give permission, ask for permission before asking more sensitive questions. And if they do at some point disclose their immigration status, whether this is an unaccompanied minor or an older patient, it's never appropriate or necessary to document someone's immigration status in writing in their medical record, because it is able to be, it's a legal document that can be brought up in court later. So how do you actually do this? How do you ask about this if you don't want to ask directly? And these are a couple screenshots that I took from that trauma toolkit that we talked about earlier. And as I said, you're really going to be asking open-ended questions and listening for clues. So you can ask about, who do you live with at home? How long have you lived there? Where did you live before? And that might lead you down a road where they'll disclose that they're from another country or that they recently moved here. And they may or may not be ready to tell you more. You can kind of let them guide how deep they're able to go in this with you. If they do disclose that they have recently arrived, and particularly for older children, if you get the sense that they may have had some experiences that they might need some support for, you can ask a very open-ended question, something like, many of my patients had difficult, dangerous journeys. Can I ask what your experience was like? And this is a good example of trauma-informed care because it starts with a normalizing statement. Many of my patients had difficult, dangerous journeys, so they know that this is a common thing that other people have experienced. And then asking for permission. Can I ask what your experience was like? And if they're not ready to talk about it, then we don't push. But if they are, it might open up and identify needs for mental health referrals or possibly other supportive services. And this just kind of summarizes what we've talked about. In addition to that, I just want to highlight the importance of also identifying resilience and congratulating and celebrating that resilience. These children are incredibly strong and brave, having gone through what they just did. And I think really recognizing that and celebrating that is important as well. As far as the treatment prior to arrival, I'm going to talk a little bit about generally that initial health assessment that Dr. Shah alluded to earlier. So when in ORR custody, a child receives an initial medical exam within 2 days of arrival, as well as a psychological evaluation within 1 day, as she mentioned, they have access to emergency, subspecialty, and inpatient care. And while they are at these facilities, because there's no parent present, ORR has medical decision-making authority. And this is typically what that initial medical exam or initial health assessment includes. Basically, a regular well child check, and then you can see the labs that are listed here. There's some specific targeted screening based on risk factors, including TB screening, STI testing if relevant, lead testing. And it is important to realize that this is what is conducted at the ORR facilities in normal circumstances. And currently with the emergency intake sites, it is possible that some of these steps are different at different sites, and there might be some portions of this exam that get deferred or postponed and are intended to happen after they are placed with a family. And this is really, this is an example of that letter that I mentioned, that each child, as they're discharged from these sites, will receive this letter. And you can see that it says, please show this letter to your child's healthcare provider. We will be providing a copy of this so you can have one for reference. But they specifically lay out in this what they recommend be performed at a healthcare provider's initial assessment. And this actually mirrors almost identically to what is in the AAP Immigrant Health Toolkit. TB screening, catch-up vaccines, targeted screening based on risk factors for pregnancy, sexually transmitted infections, fairly universal lead screening. And one of the questions that might come up is, well, how do I know what they have already received? And the answer is you can actually request records. So the child will either come with a folder that might have a summary for you already, but if they don't, and they've identified to you that they have been in ORR custody, either in one of the traditional shelters or in an emergency intake site, you can request those records. You can fax this form. There is a website that is listed on the top of this slide. This will be in the packet that we send out to everyone, so you'll have it available. There's also a hotline number and an email you can reach out to coordinate, and if you need additional information about what they might have received when they were in these facilities. I'm going to breeze through these. They're for reference. This is basically the same thing that we just talked about, that the toolkit gives you very clear guidelines on what you should be testing and in whom. And then your treatments and referrals, these are, look very similar to what you would expect at the end of any regular well child check. You're thinking about dental care, possibly nutrition resources, WIC, mental health, but then the additional things that a child might need might be legal services and potentially some education for families about access to public benefits and services. Speaking of, these children, if they are under 5 years old, do qualify for WIC, or if they are pregnant themselves, they do qualify for WIC. They do not qualify for CalFresh, but if there is someone else in the household who is considered an eligible immigration status, it's possible that other folks in the home might qualify and the family might be able to access CalFresh. If there's one important thing everyone needs to take away from this, it is that these children all universally qualify for health insurance through medi-cal. As a DHS provider, this is a slide taken from a talk I did at DHS, so they can enroll at our facilities at LA County DHS sites, but they have medi-cal, so they can go a variety of different places. They do also qualify for public school. And if they have family members that are undocumented, it's important to raise awareness that those caregivers might qualify for My Health LA, which is a good alternative for folks who are over 26 years old, who might not fall into other categories of medi-cal eligibility. Another key takeaway here is mental health. Because of what I just mentioned, they all qualify for medi-cal, which means they will all qualify for coverage for mental health services. These are a few of the local agencies I use in my clinical practice. The easiest way to access these is either to refer directly once they've already established their medi-cal, You can have them self-refer through their school district, or you can have them call the LA County Access Line. One important thing to keep in mind with the access line is by standard protocol, they will ask for a social security number, and this can be very frightening and disarming for families. So I either prepare them for it, or I often do a three-way call or call with the family in the room. It's actually not required. So what I do is I'll have families in the room with me. I will call the access line with the family. And then when they ask for the social security, I'll say, I don't have that, but here is their medi-cal number. And they say, great, and move on. And there's no problems with that. Legal aid, there is a variety of great resources in our LA area. We're very, very lucky within our county and within our state to have numerous pro bono agencies that receive funding. Several of them are listed here. There's something called the LA Justice Fund that provides funds to get legal representation for these kids because they are not guaranteed by law to have a lawyer help represent them in court. There's also something called the Vera Institute that does a lot of representation as well. If you don't know your legal partners in the area, you can use the Office of Immigrant Affairs, which is listed here. And Marissa Lau is our contact there and has graciously offered to take personal phone calls and emails, warm handoffs on patients. So please don't be intimidated by this. This is something that Marissa is very eager to help connect your patients with. As we mentioned, they do qualify for public school. They also qualify for all secondary services, including special education, free or reduced meal plans, transportation, and school-based nursing services. So this is important to inform families about as well, so they can get enrolled in school. And then a couple hyperlocal resources. Our Immigrant Health Committee over the last few years has been working on a local version of our toolkit where we had students compile community resources throughout LA County. This is a resource that's on our AAP Chapter 2 website. You can pull it up and quickly search. It's an interactive resource database that you can put in someone's zip code and be able to see what resources are in your area. We'd like to acknowledge several folks who helped contribute to these slides. We will be sharing a summary of all of these resources. So it's a one-pager that you can print and have ready in your clinic. And I'm going to transition back to Dr. Shah for open discussion and questions.
All right, so what we're going to do now is we have a few questions that we had put together, but really we also just wanted to kind of open it up. I see some people putting some comments in the chat, and so we'll go through some of these. I did want to say that I know that a lot of the resources we talked about are specific to LA County, and I will say we both practice here, and so that is part of why, but we're happy to kind of talk through options and help people figure out options in their own areas. I know there's in some of the other counties, especially San Bernardino, I've heard a lot of passionate advocates that I think will also be able to present some of the head-ups there, and if anyone wants to share those with us, we're also happy to distribute those. So let's see, I'm looking at the chat. I think so far it's mostly comments. So what I wanted to kind of open up in terms of the conversation, there's I think a few themes that we brought up. The first is how is the care different in the emergency intake? I imagine that some number of you have worked in some of these sites, either in Long Beach or Pomona. There's also been some emails that have gone out for the San Diego site, for those of you who are affiliated with any of the UC campuses. Does anyone want to share anything in terms of their experiences, things they've noticed or seen or had concerns about, or think is worth discussing a little bit further now? And Tomas, I think maybe we can turn the spotlight off and have it be a little bit more of an open, where we can see people a little bit more. One of the downsides of Zoom town halls, can't see each other.
Hi, this is Akhil Sharma. I'm a pediatrician here in Victorville, up in the high desert, and I had a comment. My wife, Aparna Sharma, she unfortunately could not be here today, but she's a pediatrician too. We are in private practice, and about 3 months back, she was approached by a private organization In fact, it's a private insurance company called Point Comfort Underwriters. And I looked it up. It essentially provides insurance for international travelers. And it was established 2014. And essentially, they wanted us to do physical examination and vaccination and care for unaccompanied minors. And that's what we've been seeing, as Dr. Gantz said, a lot of children coming in needing significant medical care, vaccinations. Unfortunately, the discussion on, oh, should we get a more detailed history in terms of trauma, in terms of what, there's little or no history available. I mean, and it's unfortunate. Our interaction with these children is minimal. These children are in the transition of being in a voluntary family. Most of them live in Fontana or down the hill. I don't know if they're a little more fortunate to have that private insurance, or it's just being provided to them. And they're in the process of being transferred to the next relative. So we basically just see them one time in the last 2 months. There's been no follow-ups. So, but I think the notes that you gave is pretty interesting, and the links that you gave, and we'll truly look into it. But in a private practice setting, it's been very tough to provide comprehensive care or get a good history on these children. I mean, I can share more experiences for those who are interested, but it's been very tough to even get records or history, or most of them are Spanish speaking. I agree, and we will not come through any people who are other or native languages, and I don't know how we would handle that. But so far, at least we've been able to provide them with care. A lot of them are young children, at least 2 or 3 young pregnant kids. One of them, at least a 14-year-old with a baby at hand. Yeah, it's been interesting.
Are these children that are in are they in like a youth, like a housing, or where are they coming from? Where are they living?
They are apparently in with a foster family, or like so I think it's after the ORR, or they are bypassing the ORR. I don't know.
I don't think they are. I think these are children that probably have gone through ORR custody and have been released into the community. We actually didn't talk about that today, but children that don't have a family that they can be, the family members or someone that is identified that they can be reunified with, the options for them are that they either stay in a shelter or in another facility for childcare for a long period of time, or they can go into foster care. And so when they go into foster care, obviously there's a lot of the services that are eligible to children in foster care that get incorporated into that. Point Comfort, my only knowledge of them is that I know that they provide the coverage for unaccompanied minors, even in the emergency intake sites. And so I would not be surprised. I don't know the specifics, but I would not be surprised if it's the same. Lisa, I don't know if you know something more.
My understanding, so one thing I've learned recently is that the children who are who are unable to find sponsors, when they enter into foster care, they actually, at least in LA County, are not under DCFS, Department of Child and Family Services. It is a separate system. And I believe Point Care Underwriters is what provides the health insurance for that entity. I actually don't even know the name. If John Harlow's on the call, he might know the name of that agency. But I believe those children, there are a few facilities, and I know of at least one in Fontana, where there is more of, not really a group home, but a facility where a significant number of children are housed after release from ORR custody. That is a foster care type model. And I wonder if that might be where some of these children are coming from.
That is true. Most of our children are coming actually from the Fontana facility, because none of the local pediatricians are willing to sign up for the insurance, apparently.
I've been taking Point Comfort, and it's a PPO insurance, and we had to redo our templates because it is very time intensive. the exam itself doesn't take very long, but they come with a lot of paperwork. And so we have to fill out the paperwork. They require that children under 2 get a PPD and a lead level. Those that are 10 years of age and older all have to, the females have to get a pregnancy test so we can see whether or not what vaccines we can give, and of course not give the live vaccines. They all need children that are over 2 need an IGRA, the quantiferin, and a chest x-ray. So really it ends up taking us about an hour per patient, but we've gotten pretty organized so that we email back and forth between the health coordinator of it's called Urban Strategies, where we're getting our patients from, but they have Point Comfort. And so she emails me, and then we we put them on my schedule. So I always reserve like an hour a day, because we want to make sure that after they see me, then they go on to the radiology department, and then they go and get their lab, so that it's all done in one day. And so far we've had different foster families that bring them in, and I've had 2 or 3 girls that have been pregnant. A couple siblings that were really delightful, and we've seen children from Honduras, Ecuador, El Salvador, and most speak Spanish. There's been one family or a couple of children who spoke some kind of an Indian dialect, but they were able to communicate with us.
Yeah. I'm sorry, where did you say you're located, Dr. Rodriguez?
I'm in Pasadena.
Fantastic.
And the same thing as Dr. Sharma, I did ask the health coordinator which other pediatricians she contacted that are accepting children. She said no one else would take them, that we were the only group that would. So luckily, I work for Kids and Teens Medical Group, so we have 10 locations. So we're easy, it's easy for us to kind of incorporate them into our practice, so it's not too burdensome on caring for our own private patients.
Yeah, and I will say, I think 2 comments on that. One is I think you're completely right about how long it takes to do the evaluation. For those of you who've ever worked with newly arrived refugees, it's a very similar thing. There's a lot that goes into the first appointment. A lot of people will split that into 2 and just schedule a follow-up sort of, to the first visit, which is a little longer, and you kind of do all the getting to know you and sort of setting the rapport, and then a second where you go over the results. You may not be able to do that depending on the setup of your arrangement, but it sort of depends, again, if you're receiving children from the community, they've been reunified with family versus if they're in some other type of care. I'll say that. And then I think, the other part is just trying to decide which parts of this you're going to do, because it is very comprehensive in terms of the lab standards. And I do think there's a little bit of a reality, right? So you sort of see what those standards are. You try to get as close to those as possible. And then, I think it is a conversation about what is realistic or possible at the time that you have and the cost, because some of those tests are expensive.
They're on the VFC program, so their vaccines are covered. However, we have to treat them as, unimmunized, basically, because none of them have come with vaccine records. So unfortunately, some of them will get 7 to 8 vaccines at a time.
Right, and I think that's a common experience, unfortunately. And have you ever used the ORR portal? I wonder if that might, it won't help with all of the vaccines, but they do often get vaccines if they're in ORR custody. And again, the emergency intake sites, depending on which site they're at, there's variable practices at the different sites. Some are, and even the same site, depending on when the child came through, whether or not they're just doing MMR and varicella, plus minus influenza, depending on time of year, versus if they're doing, more comprehensive ones up to and including COVID vaccine for children that are eligible. So
we haven't accessed the portal, but she does let us know that they don't have vaccine records. She does let us know if they have had a COVID test, and if not, if they've been in quarantine for 14 days, and then they're, allowed to come into the office.
I can speak about the Long Beach Convention Center site, because I've been working there. I'm one of the UCLA hospitalists, and so this was really helpful because it was very much aware of the CVP stuff, but not any of the kind of next steps that have been happening for these children. So thank you so much. But yeah, I think in terms of the actual medical care that we've been able to provide at UCLA so far is very, very limited. Primarily, it's just MMRV, COVID testing, and then isolation. And then all children are getting ivermectin just empirically for licensed scabies treatment. But other than that, it is pretty much very targeted testing for like symptomatic patients. So all of the routine testing that we would do for new immigrants is pretty much not happening at this time, unless they are clinically ill and need labs. But I think that just having had a couple of shifts there, it's, kind of exactly as you described. It's like a dormitory setting. The children are, working with care providers 24/7. So they have people with them at all times, but there's a lot of clear trauma. Many of them are coming to like urgent care with abdominal pain or cough, and, clearly are experiencing a lot of isolation and loneliness. And so it's very difficult to know how to, speak with them on these very limited basis, when there's very little that we're actually able to do. I don't know if anybody else had anything else to add about the experiences.
Yeah, hi, this is Cecily Gallup. I've also been working at the Long Beach Center, and thank you, Sural and Lisa, for this great talk. I'll add that in my experience, we've picked up on a few children with chronic diseases or illnesses, as well as about probably 10 pregnant girls. And so all of these kids are going on a list, and this information is being communicated to case managers who are taking this into account and trying to expedite placement and make sure that, for example, one child I saw in the intake, I figured out that he had spina bifida, a 9-year-old who, was basically having fecal incontinence and was embarrassed, et cetera. And so this child, there's definitely a lot of focus on him and like where he's going to end up, and if it can happen sort of more quickly than it otherwise would have. So that is sort of reassuring, I think, but it's a little bit difficult because we don't have very much control over, what happens next.
And I think both you and Aditi brought up, I think probably the key issue with the EIS. We presented sort of what happens in the OR facilities. We sort of talked a little bit about the limitations in vaccines and testing that's being done at the EIS sites. And again, it depends on how the EIS site is structured, but my understanding is the majority of sites are fairly limited. And as far as in terms of what they're doing, and there's two reasons for that, right? The one is that the idea is that children are supposed to be at the sites for very little time. And again, time will tell what actually happens. And again, we haven't talked about this piece, but I do think after I'm done giving the overview of the EIS site, we should talk a little about the advocacy piece. But, the EIS site, part of that is if the children really are only going to be there for a short period of time, then is that the right site for the full medical evaluation, or should it be once the children are out in the community? And I think there's a lot of discussion to be had there, because will it really slow down their release? And I think the question is, can you definitively say it would? Because I think that's the argument that's been made in saying we should do a limited evaluation. And again, there's a discussion there. The pregnancy issue, I think, has been one nationally that has been brought up by people working in the EIS sites. And there are legal protections, just so everyone knows, in place for immigrant children. Called Garza. There's some kind of, I think it was a settlement where children are supposed to be able to have full access to reproductive choices. They should not be limited in their reproductive choices. And so I just want to sort of say that across the board, but it is something I think that has been coming up. It's a population that includes, females that are able to get pregnant. And so it does happen. The other thing with the EIS sites, Aditi, I think you were sort of bringing up, is just it is a limited evaluation. You often only see the kids one time, and how do you handle that and not traumatize the kids? And I think the solution for many people is not to ask very many questions unless there's something medical that comes up. I think that's hard for some of us, to not want to build rapport and have a conversation, even if you're not asking specifics of tell me all the horrible things that may have happened to you, even if you're just saying, tell me about what your last 24 hours was like, it's tough sometimes to not ask those questions. And I do want to acknowledge that.
Yeah, I think any tips on language about how to ask those questions. And I think in Lisa's presentation about open-ended questions and not pushing, but kind of normalizing it by, I have many patients like this, and what is, what was your experience like? That was really helpful to hear that. So any like tips on language is really helpful.
Yeah. There's a comment here, Nisha, it says, Abdul, I think your name is Kader. It says, any suggestions? We've been told that a large number of minors are going to be brought to a local military base. We've tried to reach out to the local ACLU to help support. It seems like it's pretty controlled federally. I actually don't know anything about that. I don't know if anyone else has heard anything about that. These are immigrant children. I don't know if you're able to speak. Feel free to reach out to us and, oh, here's someone's phone. Yes, they're immigrant. Okay. I don't know anything. Where are you located? Oh, okay. I don't know. Lisa, have you heard anything?
I haven't. I wonder if, depending on how recent this was, when sites were popping up for new EIS, I know that there was a lot of different sites, including some in Central California, that were being entertained. I don't know if that was maybe a possibility and then that is no longer going to happen, or maybe there's newer plans that I haven't heard about. I'm not familiar with anything, any other new sites in our chapter area other than the two that have opened.
Yeah, feel free to reach out if you hear anything else, and maybe someone in the group will know, or in the chapter will know.
I think there was some children housed there during the surge in 2014. I know there was some in either Ventura or San Luis Obispo County. So I don't know if maybe that was revisited, but ultimately they determined Long Beach and Pomona to be the sites.
We don't have a lot of time left. I did want to sort of, the two things I wanted to talk about were, one was about just transitioning into the community, which is just, again, I think as people are thinking about this, and as you hear things, I hope we can serve as a resource and network. I also want to say Dr. Gantz, that toolkit that she presented, she really spearheaded putting that together over the last few years. And I do think it's a very useful resource for those of you, both in LA County and outside of LA County, because a lot of the resources are California specific as well. And so definitely take a look at that now. And again, as a reference, you'll have it. So if you need it, then you can sort of, have a starting point there. I think from an advocacy standpoint, for those of you guys that are seeing kids in the EIS sites or out in the community, I can tell you my sort of thoughts, but I'm sort of curious if there's things that people are seeing or thinking that they, think are important avenues or areas for discussion as pediatricians who are sort of, experts in child health, right? And are in these settings and may have views or thoughts on how things are being handled. And I can say, to start us off, like, I think the discussions around contraceptive issues, things about how much should we do, in these sites and what is really in the best interest of the child, those to me. I think the other thing is how, to me, from an advocacy standpoint is, as we see this large number of children, like, what is our federal government's responsibility in making this transition into the community smooth? And from a medical standpoint specifically, that portal, those of you who have tried to use it, is clunky. It's very difficult. You have to fax things to them, right? I mean, even medicine is coming away from faxes slowly, very slowly, but it's happening. So I just, I think that there are places that we might think of from an advocacy standpoint, thinking about access to legal services, thinking, we're lucky in California that children have access to healthcare, but again, trying to think about in other states and nationally, what are we advocating for? And I would just, encourage everyone to sort of reflect on their own experiences. And I know while you're there, it's really just you're trying to get through the intakes. It's there's a lot to do, but I just want to make sure that we're continuing to discuss. For those of you who are not on our chapter's Immigrant Health Committee, if you want to join our list, feel free to reach out to Tomas, and he can connect you to me. We can add you to our discussion. But you know, I think the other part is how do we partner with other people in the communities that are going to be receiving children. We've talked a lot at our last Immigrant Health Committee meeting about teachers, about schools, and trying to think about how to partner in those settings as well. And so there's definitely a lot more to talk about here, but I think trying to think through those in a proactive way now is, I think, beneficial for all. All right, any other comments? I'm trying to look in the chat and see if I'm missing anything else. There's a few people that have sent me direct messages. Feel free to, you can contact Tomas and he can pass on any messages to me as well. I can put my email in the chat as well.
One thing I just want to highlight, if anybody's really passionate about this issue, is Chris put in a great suggestion about connecting with immigrant community groups. And I think there are some very robust active groups, both advocacy-based, legal-based, grassroots community groups that are poised, I think, to really tackle some of these tougher, more complex issues. And one forum that I think we as a chapter and as physicians could play an increasing role in is there's actually a collaborative called the Unaccompanied Minors Collaborative that's led mostly by the legal community. They meet once every 3 months. I believe they're primarily LA County based, but they definitely have some staff that represent other counties within our chapter. And I've been at a few of these meetings from time to time, and I'm very frequently the only doctor in the room. And I think that's a really great place where we could connect with some of our partners in different realms. So if anybody's interested in those, we can maybe include that information on our next listserv blast out, because I think that's a really great opportunity for us to maybe connect with other disciplines.
All right, and I think a few of you may have completed the application through USA Jobs for the HHS sites. I think they are starting to send some communication out, but I think it's coming through the academic medical centers. I'm not actually sure, but from what I've seen, I think the sites are going to, they'll set up, I guess, what they have. The UC sites, for example, I know I don't think they're offering housing, but they have like limited, like lower cost housing is what I saw for UCSD for healthcare workers that are coming. But I don't know all of the details of those sites, and I don't know what exactly they're going to do with that HHS list that many people signed on to. And if you don't know what I'm talking about, there was a call from the AAMC for people to sign up as volunteers to work largely in these EIS sites, and HHS was partnering with AAMC on that. All right. I want to be mindful of everyone's time. I know it's late in the evening. Lisa and I are both available if you guys have any other questions or want to talk a little bit more. And again, feel free to reach out to us if you want to join the Immigrant Health Committee as well. Tomas can connect you. And then if there's anything else that comes up, again, the idea is for this to be an open forum for conversation and dialogue and to advocate for the children we're seeing and caring for.